So I just introduce you to, this is George, who sat in my office for probably 40 years in various places. Neurosurgeons don't have them as often, nor neurologists, but orthopedic surgeons and physicals. There's usually something like this stuck somewhere in a place, or separate joints. But it's very helpful for things like this, the kinds of stuff we're going to be talking about, because you can actually show people up close what's going on and compare imaging studies with this, so you get some idea of what's going on in the back. Actually, this is, come on. This is timely, because I've always thought I was very healthy and never had any back trouble. In getting ready for this talk, I got back trouble. So anyway, so it happens. And I think it was probably my mistake. We'll get to that later. Sarah Bowers is, and here we are, there she is.
Hello.
Has set this up very, very nicely, so appreciate that, Sarah. And there's a nice little video clip toward the end. So actually, there are a lot of really good educational things which I wasn't aware that the library could do, but they're available from good places. So we're going to try one today on epidural injections of steroids, which is a common thing to do for people who have back pain and sciatica, that is improving. So, well, let's march along here. It wouldn't be me if I didn't start out with something that had to do with evolution, and we are bipedal, right? And in a way that got us into the trouble with the back and the neck, especially the lower back and the neck. Why? Because that's where the curvature is. Quadrupeds don't have those curves in the neck or in the lower back, so they're not nearly as prone to the kind of troubles that bipedal species, mostly us, are. And it's often very age-related, no surprise about that. By the way, that Jeremy De Silva's book, that's a gem of a book. First Steps, How Upright Walking Made Us Human. I mean, that man has a good sense of humor, but he also knows his stuff. And he's really an evolutionary biologist. So if you want to learn stuff about feet and backs and that kind of thing from quite a different perspective, great source to go to. So let's see. And of course it wouldn't be me if I didn't include this, because when we walk, we leave footprints. And I just finished writing a little article this morning about that glacial, interglacial cycle every 100,000 years, and which really dictated when migrations of pre-humans and humans took place, because otherwise, well, Saudi Arabia these days is an Arab desert, but it wasn't in the last kind of interglacial period, when it was lush, had lots of water, lakes. The only reason why we know about the lakes is from satellites, and realized that Saudi Arabia, what all looks like desert now, had lakes, big lakes, rivers, streams. That means plants, that means animals, that means a good place to migrate through. You have resources to keep you going. And that applied to the Neanderthals and modern humans. Well, getting back to the footprints, I mean, this isn't blue sea, but it could have been blue sea. The interesting thing you probably noticed, if you look up this kind of closely, I mean, this is the adult, right? And the adult's walking very slowly. We don't walk that slow, where the feet are almost a length between. This is a leisurely walk. And the kid here is a foot half the size, and a longer step here. Oh, hi, come along. We're doing a really interesting stuff here. So, anyway, there's, so the article is right up it's the same time period, 110,000 years ago. So when Saudi Arabia could be traversed because it had game, had water, that kind of thing at that time, there are footprints of many animals, but there are also footprints of modern humans crossing, migrating. And by the way, we talk about out of Africa, but they went in both directions. And it wasn't a long trek for a year. There would have been short treks, camping, and some of them might have gone on, some not. So it wasn't like the going west with wagon trains in those periods. And but then there was around the same period, this remarkable set of prints of 37 must be Neanderthals, because there are no modern humans in South Spain at that time. 19 or 20 of them were adults, and they were just ambling along, close to one another. And the kids were doing what kids do on a beach, the southern coast of Spain, jumping around and playing, and out ahead of the adults. I mean, it's a typical beach scene. It could be us. It could be any beach, any place. And the adults, I have to think they were talking to be that close to one another. So they must have had language, I think, some version of it. And so it's really interesting. You don't get that same sense looking at skulls, but I think feet tell you more. It's like the lady in New Mexico 8,000 years ago, a woman who's walking along in New Mexico in a leisurely pace, and she has a child. And periodically, she's carrying the child on her hip, on her left hip, and periodically lets the kid down. Maybe the kid was squirming or whatever, but the kid gets down, so you now see footprints. And along the way, the track crosses the path of a woolly mammoth. And the woolly mammoth, just from the prints, paid no attention to she and her, I presume her daughter, or her son, I suppose it could be, I don't know. But anyway, and then a giant sloth, I mean, giant sloths are big, and it clearly stopped and paid attention. But her prints didn't change. I think it's a really interesting encounter. I mean, holy mackerel, who was she? What became of her? What became of the kid? Obviously, she wasn't afraid of the giant sloth or the woolly mammoth. And so interesting footprints. So put this in. So it may be the most interesting part of the talk. So here we. I don't know where that. So prints. Well, here's that point I made about the book. By the way, I rather like this one. I was thinking about this about an hour ago. I'm wondering about every one of us was like that at one time. I never quite thought about that before. One time we were connected. You know, like one of Elon Musk's kind of hoses bringing nutrients in. That's a bad name to bring up right now. But anyway, connected to Mom. And now we know that that kids of that size are already learning. The brain's already learning. And so in response to the environment. But you can see the curve here. This is where the curve is in the lumbosacral spine, and this is where most of the trouble occurs in humans. And to a lesser extent up here, there's another curve up the neck. There's a lot of mobility in the neck. I don't have the mobility I used to now. But a lot of rotation, which you don't have down here, and flexion and extension. all of that, and consider that all the weight of the body, of the upper body, is now on these lower vertebrae. So is it any surprise that beyond a certain age, things start to go wrong? And after all, that happened to pets and their hips and that kind of thing when they reach a certain age, when we get older. So, well, I love this one. It looks busy. This is a friend of mine who wrote a really good article in the New England Journal of Medicine with his resident on sciatica. And it's crowded, but really outlining the kinds of things that can happen. Where can I have? Here we are. Kind of lost it. I lost the tip. But anyway, if you look at this, I mean, that's the pelvis, and here's the cauda equina, the horse's tail. Remember, the spinal cord actually ends at between L1 and L2. So we don't have to worry about the spinal cord in the lumbosacral region. But all of those nerve roots are all gathered together in a bundle. You see them later in the CT scan and MRI, but there's a whole bunch of them. And they're kind of floating around in water, cerebrospinal fluid, but water in a bag. And they exit at various spaces here. And in this case, some of them form the largest nerve of the body, the sciatic nerve, which goes out to the sciatic notch, which is what I think I probably did to myself here on the elliptical trainer. I'll tell you about that later. But anyway, but here's the classical one. Well, we'll get into more of this here, but here's the classical one. Here's the L5 vertebra, first sacral vertebra here, L5, L4. Almost all, 80% of the trouble is at this level or at this level. Between L4-5 and 5S1. You've got 90% of the trouble. And here's a disc protrusion. These roots need to find, in young people, there's a lot of room for those roots. They can move around quite easily, but when we get older, the disc kind of flattens, begins to bulge. The bulge crowds that space for the root to get out, and then you have degenerative changes in the joints, these posterior joints here. We'll talk about that a little bit later. But anyway, and sometimes it happens that a vertebra will slide forward on the one below. That's not a good thing, because that really does crowd the space. So enough of Alan Wolper here. Well, here we are. And by the way, other things other than neurological problems or neurosurgical ones cause troubles with nerves and the pelvis, that kind of thing. Tumors in the pelvis, big masses in the pelvis, obviously. These sacral nerves are all very close. And of course, here's childbirth, right? And if it's an awkward one or a difficult one, or the head's not turned properly, then it get jammed in that space. Not good for the kid, not good for the nerves. And but I must have paid a bottle to have the artwork on that one. Here's, don't have to remember this, but this is your little vignette that we're going to talk about a little bit later, because it's the worst kind of thing that kind of happens to most people. I'm not going to tell you what it is, but here's the story in the kind of arcane language of the New England Journal of Medicine. Okay, so you can make your own diagnosis here. So a 72-year-old woman, not very old by my standards, 6-month history of lower back pain, back into the buttocks, thighs, legs, and tingling in the tops and bottoms of the feet. If it's tingling, you know that the nervous system is involved. Pain doesn't help you a lot. Pain isn't a very good indicator of where a problem is and the nature of the problem. But tingling does. It's very specific. It's very, very helpful. Know that. But look, she used to walk 4 or more kilometers a day, probably like most of half of the whole town on a daily walk. Now she's down to 2 blocks. and that's very uncomfortable. And the pain forces her to stop until the pain eases up. And she's what I see in the community, the person who's walking like this into the grocery store, get out of the car, or in church, kind of bent over. So that's the worst case, which we'll kind of talk about a little bit later. But it's not all. Well, how prevalent? Well, it's really prevalent. So 2/3 of adults at some time experience a bout of low back pain, and sometimes associated sciatica is a word that means nerve pain. Doesn't mean the sciatic nerve, but nerve pain. For most, the pain resolves, and within a few weeks, that's the usual story. I have a very good friend in London who's he's within 4 weeks of me in age, and an engineer, and for I think almost 30 years, every once in a while, for several days, he has a bout of back pain and leg pain, and he obviously has nerve trouble because I've seen him a couple of times, and he has wasting actually some of the calf muscles, so I know that that's happening. But he's done really, really well. No surgery, stayed away from surgeons, which is a good thing if you can do it. And well, no surprise, some people have a single bout of it, but more often people have, if it happened once, it's going to happen again. Well, the risk factors, we've already alluded to some, but age-related degenerative, I mean, that's got to be right at the top of the list. Aging is not great. I mean, I mentioned this last week, and I mentioned it in the series on aging. Systems start to go. Almost every defined system within cells, any kind of cell, starts to fail, beginning in, say, the 50s and 60s. That's when our hair changes color, our skin loses its elasticity. We don't look like we were. And the changes can happen fairly fast, right, between about 50 and, say, 70. And beyond, as you looked at, saw Clint Eastwood the other day with Trump. Boy, Clint Eastwood, 92, he looks 92. He looks a really fit 92. It's really good. There's no doubt he's in his 90s. And it's the skin, that kind of thing, that kind of gives it away the outer thing. So we know that. Okay, so, sports injuries, no surprise here. I mean, people who play contact sports, you know, kids get away with almost anything, up to athletes do, up to into their early 20s. But in professional sports where they're still playing into their mid and late 20s and 30s, there's the cumulative injuries. And tennis, which I follow, is pretty obvious. You know, they've got their career, their professional career is about, 15 years at their peak, 10 or 15 years at their peak, and then they're headed down. And a lot of that is because of cumulative injuries, their elbow, their wrist, their shoulders, their back, you name it. But it is age-related, but also cumulative trauma. And these are the obvious things we know about, right? Lifting and twisting, at this time of year, shoveling compost, and that kind of stuff, not so much snow. But it's that lifting and twisting and turning. And you got away with it for 50 years or 60 years, and then one day you didn't. And if you've ever been, maybe for very good reasons, on corticosteroids, that increases the risk. So if you have arthritis and somehow end up on corticosteroids for good reasons, it also increases the risk of, it weakens ligaments. And joint capsules, that kind of thing. And they kind of thin out. And so let me see. Now I'm going to go point out some of these things because I don't know whether you can see this stuff. If you want to sit up further, see, this is kind of a normal vertebra right here. Yeah, and just looked at from on top. And of course, there's the vertebra and the disc. This is the disc. The central part of it is kind of soft. The outer part is fibrous here. And then there are posterior joints. So where's George? So George, I mentioned this because the orthopedic surgeons pay a lot of attention to these back here. These are all these posterior joints. 1, 2, 3, 4, on both sides. You can see, you pass it around if you want. But, so if something happens to these posterior joints and they thicken up and become larger, they intrude in the path that the root is going through. Okay? And the other thing that can happen, there, be quiet. No, be quiet. So just compare this with this. So there's a lot of space here. In a normal person, meaning somebody in their 20s or kind of early 30s, there's a lot. If you did a CT or an MRI, the sac containing all the nerve roots has lots of room. They kind of flop around. Nothing's happening to it. And the ligament at the back, the ligament inflatum here, is really quite skinny. But look what happens with aging. It thickens and it begins to crowd the space in that canal from behind. And look at the change in these posterior joints. Those are normal posterior joints, but here you can see the degenerative changes, the thickening of the bone here, rubbing up against one another, a good source for pain because these are all pain-sensitive structures. And here's a disc protrusion. So if you combine the disc protrusion with that thickened ligament and thickened posterior joints, you've now crowded what was a big space into a small space here. That's what's happening with aging. And you can see it in the classic pattern. I mean, here's a side view here. So there's the L5 vertebra, L4, L3 here. Here are the two troublemakers, L4, 5S1. So that's how high a normal disc should look like. But if you go down between L4 and 5 and 5 and S1, it's half the height. So that disc is dried out, it's compressed, and the edges have kind of pushed out laterally, crowding the immediate environment. And what is the immediate environment? These nerve roots trying to get out into the pelvis. So the disc is drying out, it's flattening. That's why people get shorter when they get older, primarily because of the discs kind of drying out and shortening, but also because the vertebra itself may actually break down. And I remember being stunned by a fellow when I was at Tufts University Medical Center. That was in the middle of Chinatown in Boston. And I met a most interesting fellow. He came in, culturally, his daughter brought him in, and he was a lovely man. He was involved in Mao's retreat from the nationalists into the mountains to the west in China. It was the Long March, the Great March. And when I looked at his spine, almost every level, vertebrae, there had been fractures, and the spaces between them kind of really squished. So I asked him, I said, well, gee, there must have been symptoms at some time. And so we got talking about the Long March. And he said, yeah, sometimes it was really awful because they were carrying kind of 100, 150 pound packs on their back up and down these mountains. And and there was no stopping. So if you had symptoms, you kept going. And he remembered a number of times when it was just almost unbearable. So clearly that's when most of it, I think he's carrying this unnatural load under extraordinary conditions for a long time, and probably not being fed properly, so nutrition wasn't probably there. So a lot of factors playing into his back, but I'll bet he was probably 6 or 8 inches shorter than he might have been because of all this change in his spine. He was just a lovely man to talk to, and so was his daughter, but where are we? So, interesting the culture too, because in the downtown area of Boston, there was a Chinese community, and then beginning in the 1980s, people were getting out of Russia. And they had open doors on immigration. Trump would think about that now. But open doors on immigration, a lot of Russians. So I mean, there are a lot of Boston Irish in the area, but the new immigrants were Russian. And interesting enough, the old generation never learned English. The middle generation had to work, and they learned English really quick. And the kids, no problem at all. Interesting to see how that kind of stuff plays out. Well, this Alan Roper was a colleague of mine in Boston, guy. He's now a senior editor of the New England Journal of Medicine, an excellent teacher. Harvard turned him down for a long time for tenure because he wasn't bench science. He was a really good clinician. He was really good with patients and sorting out problems. And this one, now he's one of the lead editors of the New England Journal of Medicine. He gets to push some of his own hobby horses, and this was one that's on. Actually, he made a mistake, I think. I told him one time he made a mistake because the article the title was sciatica. But it isn't sciatica, that's a sciatic nerve. Sciatica doesn't mean nerve roots in the back. But in the common parlance, the street level, sciatica somehow is mixed in with it. Anyway, this is a beautiful example here that the artist caught, because here's the end of the spinal cord. Here we are, L5, 4, 3, 2, 1 up here, so the spinal cord would end about here. And here all this horse's tail of roots going down here. And there's a posterior protrusion facing back and catching one of the nerve roots. And one of the ways you can figure that out is get somebody on their back and lift their leg up, essentially stretching the root. And see where the symptoms are. Not so much the pain, which doesn't help, but if they tell you, if he, in this case, he was probably, if he had sensory symptoms, it would probably be tingling, but the tingling would involve his big toe and the top of his foot and the side of the calf. That's classic for L5, absolutely classic. And if they describe tingling in the side of the foot, the outside of the foot, and the baby toe, that's classic S1. So tingling is diagnostically is really, really helpful. It tells you exactly which root is involved, is symptomatic. Pain does not. It's kind of too diffuse. But anyway, one way of precipitating pain is, and Alan, the artist probably, the photograph was probably taken of Alan doing this. And then drawing that. By the way, the artist completely screwed up the nerves in the foot. So I told him. Alan's a good guy. He's and excellent. very good clinician, as I said. Well, sometimes you get two for the price of one, unfortunately. And here's an example of that. If the disc, here's a schematic here. So here's L5, L4, 3 up here, but L5, and this is the top of the sacrum right here. Well, these two roots, the L5 and S1 root, are actually quite close together for a long time. And where they cross the back of that disc between L5 and the first sacral vertebra here, both can be caught. So somebody could have symptoms of both. And if there was a surgical procedure, one level would do to decompress these roots. You follow what I'm saying here? And well, this is just another, I don't know if there's anything to be said here, but that's a good one, just illustrating. Yeah.
Can you show us?
On George?
Yeah, just where L5, L4, S1.
Yeah, sure. That's what George is for. By the way, I don't know whether it's George or Helen. Are you Helen? No, okay. So that's this is the sacrum right here, right?
Mm-hmm.
To here. So that's the first sacral part of this.
Yeah.
So that's L5,
Okay.
L4, L3, L2, L1. The cord ends between these two.
Right.
Okay. So these roots here, that's the first sacral root coming out.
Right.
It actually comes out through the sacrum. That's S1.
Right.
There's L5, L4, L3, L2, L1.
Okay. And just curious,
Yeah.
above that is these new.
Well, 5, 4, 3, 2, 1. These are the thoracic vertebrae. And by the way, they were just as much involved in that Chinese fellow as, and people with osteoporosis and osteopenia. It's the thoracic vertebrae sometimes collapse a lot.
Okay.
Yeah. Do you want to hold George? Yeah.
I have a disc issue myself, and I've always wondered, what is the normal size of the disc? You're saying some have compressed to half the size.
Well, these are, I mean, this is artificial, right?
Right.
Yeah. These represent pretty good what the normal disc would be.
Okay.
This kind of rubbery stuff.
Yeah.
But they can compress to half that or less. And you can see the result if that happened just from the rear. You open it up. Boy, if you compress that, well, I don't know whether you can see that just because we were working over here, but this is where the nerve root is coming out. This is that posterior joint here. You can see if that really became thick and swollen and degenerated, or even a bit of it squeezed out and compressed that nerve root. Boy, does it ever crowd the space?
Yeah.
Yeah, it hurts, exactly.
I know.
Yeah, okay, yeah. Oh, George. George is yours.
Very good.
Can you say a bit more about what you mean when you say the spinal cord ends? But of course, the nerves, many of the nerves continue.
Yeah, they continue down.
And so what's the structure that defines the spinal cord and what disappears when it ends?
The tip of the spinal cord ends. Actually, let me go back here because I don't know whether that showed in the back here. Yeah, all of these nerve roots are contained in a sac, and kind of a dural sac, it's kind of thick membranous sac, and then they exit it. It's like going, this is the QEW, and you're exiting. This is the first turnoff, or the second, or whatever it is. And it's where they exit, where most of the trouble occurs. Out here, posterolaterally or laterally, not so much in the center. Sometimes in the center. When it happens in the center, I'll show you an example of that. It can be devastating because there are a lot of nerve roots. Let's say you had a central disc right here that went directly back. It'd catch all these sacral roots, which means your bladder, bowel function would be affected, as well as your motor and sensory functions in the legs. That's not a good thing. Fortunately, that's very uncommon.
So is it too simplistic for me to think about it as a tube? The spinal cord is an enclosing tube, and the tube ends, but of course the...
Well, the spinal cord is the size of my finger in diameter. It only, when you see a scan of it, you will see how much space it occupies in this dural sac. It's not much. Spinal cord is not big. A lot of stuff crammed in it, but it's not big. There's a lot of room there for trouble with no symptoms. Meaning it may take several decades in your life of these changes at various joint levels and that kind of thing before it reaches a point at which you might develop symptoms because you're really sitting on the line, and then you twist and lift, and bingo. One little bulge at that point, and you've got symptoms. But you've been getting there for some time. So we're all questions are good. What's nice about a small group like this? You can ask. Oh, I did that. All right, so off we go. And, oh, okay. All right. Now here's an MRI. Now, just follow me through here because part of the this is a horizontal slice through here. This L4, L3, 2, 1 spinal cord. You can actually see it end here. There's the spinal cord, the tip of the spinal cord right there. That's where it ends. Tip of the spinal cord is really the end of the central nervous system. The spinal cord is all an extension of the brainstem and the rest of the nervous system, right? So the spinal cord is ending here. But you see how much space there is? Let's take the more normal levels here. There's kind of a normal height or fairly normal height of a vertebra here. The discs are probably a little flat here. But at least they look fairly, not bad at all. I don't know how old this guy is, but I would think probably 50, 60, something like that. By the way, white here is water, or cerebrospinal fluid. So that's the sac. All of these nerves are hanging in this sac. And what you're looking at is the CSF around it. So there's a lot of room, right? Until you get down here to L4-5, and there's the disc right out, big chunk of it, sticking right out here, which I outlined in red here. So that's an L4-5 disc. And then you can really see the trouble. By the way radiologists do this, this is not the right side, this is the left side. You're standing at the feet looking out. Yeah, so the compression of the right L5 root is on this side. So this is right, this is left. But here's that vertebra here, and you can see the bulging of the annulus around here and the bony overgrowth here. I mean that's what's accounting for this red bulge here. There's that posterior joint I showed you. It's degenerated, it's thickened, it's crowding the space here. And then on top of all that, if that wasn't bad enough, there's the disc protrusion right there, or part of it right in here. So, and there's the nerve root right here. There's the nerve root, that's the dorsal root ganglion right here, and that's the nerve kind of headed out here. But you can see there's very little room for the thing here. Normally, there's a lot of room there. Somebody 15 to 25 to 30, there's a lot of room. There's no room there. If this is a parking spot, a big car's in it, there's almost no room to go forward or back. And compare that with the other side. You see how big the space is? Is it normal here? No. But it's a lot more normal than over here. And there is degenerative change in this posterior joint as well, but there isn't any disc protrusion. And by the way, that's the dorsal root ganglion right there. Right there. You do not want something hitting that, because that's where all the nerve cells are, for sensory fibers. Okay, pain and other sensation. By the way, when you look at this, there are freebies when you look at MRIs. When you look at this, these are the paravertebral muscles along the spine that provide a lot of the support for the spine, for the back. But a lot of this muscle has been replaced by fat, because the fat is this white stuff in here. And there's a lot of that, FAT, around here. So I would judge this person probably overweight, but maybe more importantly than the weight is that the muscles aren't as robust as they should be to support the skeleton of the back, okay? So that's a bit of a freebie on the scan. They did manage to get a cut here right down the middle here, because you can see the spines, the spinous processes along the back. So it's actually a good picture to show. Where are we here? Now, the only reason why I put up this is that, you know, degenerative changes in the back are 98% of trouble that when we're talking about back pain and leg pain. But you really, not all, because unless you think about other things, you miss them. And this person actually has an abscess right between these two vertebrae, and it's eroded into the vertebra above and below here, and then you check it here, and it's actually pushing backwards on some of those nerve roots. That would be a hell of a thing to fix, except with antibiotics. But the other thing, what's big in our age group? Cancer. If you're male, prostate cancer, because that's where the spine, that's where the metastases go, to the lower back of the spine, vertebral bodies, that kind of thing. And particularly with an aggressive prostate CA. So I'm only putting it up there that I think when people in an office who are seeing a lot of patients and they realize that the great majority of people coming through their door have a common degenerative problem, which we've been talking about. But unless you think about this possibility, you're going to miss it and lose an opportunity to really help somebody.
So would a cancer look the same as an abscess?
Hmm?
Would the cancer look the same as an abscess? I don't know.
No, that would not be missed by a radiologist if they saw it. But in this day and age, sometimes you see the family docs can pull up the stuff on their own screen and they read their own stuff. Well, they're not very good at reading the stuff because they haven't seen enough of the stuff. And it's also one of the issues sometimes with, because then what the person knows is what the report said. But really, when the system works well, the person looking after the person should be looking at the films with the radiologist, the same films. That's when it works. It doesn't work nearly so well electronically. So that's important. So when in doubt, my thing to check myself. And learn about it, so.
Based on your readings, sort of a sidebar question, do you have an opinion about the emerging value of AI assistance in radiology assessment?
Oh, I think AI is a real threat to AI is probably going to take over most of imaging. It's incredibly, it hasn't done it so far. And you can imagine, and there's kind of a dangerous interregnum here between, well, AI is getting better, but isn't where it should be, but it's seeing enough of them that the radiologist isn't seeing enough to learn from their experience. Do you follow what I'm saying? So unless the two of them are actually looking at the same films, which is where the power of a Mayo Clinic or the Cleveland Clinic or Harvard or a place like that, or maybe in Toronto, some places, but anyway, where people, everyone sees the same thing. And it's particularly important as AI evolves and is developing, but there's no doubt in my mind that the way this is going, because it's incredibly good at looking at pathology slides, it's really good at looking at skin lesions, it's getting really good at looking at MRIs and CT scans, and why wouldn't it? It sees thousands and thousands. Now, what is the database? Is based on, in its learning database, is coming from physicians saying that look for this. So you may have the wrong persons. So there clearly is a curve here. And you really need to vet the information that goes into AI if it's going to learn the right things. But once it does do that, it's incredibly helpful. And you can imagine, if you lived in a remote community, it's very common in the northeast United States, in Maine or New Hampshire, kind of thing, and if you had a radiological suite and a capacity for doing MRIs and CT scans, do you actually need a radiologist there? No, the answer is you don't, because AI can actually read that stuff. And because it can all be checked online, there's a backup there, okay? And that's happening in Canada, in kind of remote areas. And now, of course, it's getting into major centers. Well, I've already said some of this stuff, so I'm not going to repeat myself, but, oh, sorry, it's already there. Well, these are the common ones. Now, there's three things that go into getting the diagnosis right here, meaning what is the problem, what's the localization. Number one is the history. How good is the history? It's really important to get the history right. How long has the problem been going on? Has it been episodic? What are the symptoms related to any activity or not? And specifically, where are the symptoms? Especially tingling and numbness, meaning cutaneous sensation. That has real diagnostic importance, real localization importance. It will tell you which root it is with a high degree of confidence, meaning well exceeding 95%. So get the history right. Then does the examination that you carry out fit with the story you got? So if somebody reported tingling, but it was intermittent tingling, and they didn't have it right then, could you demonstrate any tingling or weakness, for example, in the L5 territory, to support your presumptive, this is L5 or S5 or whatever? And then do the imaging studies fit? I mean, it's like a steeplechase, and you have to, there's an order to this, and all those players, the history, the examination, and the imaging studies have to tell the same story. If they don't tell the same story, you're in trouble. Because what are you actually managing? And especially, this will come up, with surgery. And especially if you're looking around the room, our age, where it's almost certain that that there are multiple levels involved. Imaging shows everything, but it doesn't necessarily show what's relevant. Do you understand what I'm saying? So it's really important to interpret what you see in the films in the light of that story and what you found in the examination. That's why Alan Roper is as good as he is, because he does his homework right. And everyone he teaches does the same thing. But that tingling is the most important thing. I mean, I've never seen anyone with an S1 group that had tingling in their big toe, ever. And I haven't seen it in the lateral side of the foot that turned out to be an L5. Doesn't work that way. So the wiring of the sensory system is pretty specific, especially the further out you get in a limb. And and here's another thing. I like this one because this is MRI studies in asymptomatic adults. Asymptomatic adults. People without any symptoms or history of problems. People under 60, a fifth of them had a herniated disc, one or more. Half of them had a bulging disc at one or more levels. Degenerative changes in almost half. Now, judging, well, not all of us here, but say over 60, being late 60s, 70s, into the 80s. If it's in the 80s, you could add more to this number. A herniated disc, a third of them. Bulging disc, 80% of them. Degenerative changes, over 90%. So that's what the radiologist faces. These kind of changes are really common in the absence of symptoms. So if you saw this patient and they gave you a story, what in those imaging studies is actually relevant? Follow what I say? Some surgeons are really bad about this because they all they want to see is the MRI. You kind of phone up with a consultation or something, they send over the MRI. Then they make their decision about whether they can operate or not based on the MRI. Never talk to the patient or examine them. Now, I'm not saying they don't do that, but you see where the priorities are screwed up. Number one is the story. Number two are the findings. Number three, in that order, are the imaging studies for this very reason. Okay? So that's really important. By the way, that applies to the neck next week. Same kind of thing, same problem. Well, sort of did. All right. Well, I don't need to go through all of this stuff. And I've already said this. Most people get better. In the young, a third of them are better in a week. That fits with my experience. But the recurrence rate of acute back pain is actually fairly high. Like my friend, another Peter. I put this in red because acute low back pain that shows no evidence of resolving within 2 to 3 weeks or is associated with odd features that don't fit needs to be investigated. Think some other cause, okay, other than the degenerative changes. That's a really important thing. Management, well, I don't. Little evidence. There's very little evidence-based. There's very little evidence-based information on almost everything that's done for the back. And as of 2025. The internet is full of stuff. There's all kinds of stuff on YouTube about this person doing that or offering this or that. Doesn't mean that they don't help people sometimes, but it's very hard to predict who they're going to help and how much they're going to help, and if there's any risk to that. So we're not talking about solid evidence here. Oh, sorry, I did that. So back here, well, it's pretty obvious. I mean, look at the, whenever you see a treatment list like this, you know no one's got it right. If you got a list of more than 10, some of them work some of the time, you know, anecdotally, but a lot of it is anecdotal evidence. And I'm not making light of it because sometimes it can be really helpful. And I'll just tell you one little story because a very good friend of mine, another Peter, that I knew very well in London, moved up to Vancouver. And Peter's is an engineer, another engineer, and very straight kind of guy, meaning hardworking and responsible and not someone to cry wolf at all. And when I walked through the door, it was obvious Peter was very uncomfortable. His wife kind of gave me the eye. And Peter didn't say anything, but the next morning at breakfast, Peter said, well, I'm going out for morning. It turned out he was going out to his chiropractor. And Peter didn't want to tell me he was going to a chiropractor. So I said, well, would you mind if I came along? And said, I'll keep my mouth shut. I'm not going to say anything. I just want to come along because I actually don't know much about it. And I've had several patients swear by it. So I just want to know. And so we went off to this fellow in Vancouver, and he described x-rays. I certainly didn't see the x-rays that he was seeing. But was Peter better when he came out of there? He was a lot better when he came out of there after the manipulation. And he was not a guy that you could fool. And that sent me on a little different path. Because I thought, I don't understand what he did or why this worked, but it clearly worked in this case of one.
For how long?
Well, for Peter, he'd had other experiences like my other Peter that would go on for maybe a week, and then the symptoms would go and clear. And this was his way, because we were there for 2 weeks, and he didn't want to be, wanted to be,
Yeah.
okay,
So
and he was.
So he was fine for that 2 weeks?
Yes, he was, yeah.
I've heard of some people that go for like to a chiropractor and then they feel great coming out and 3 or 4 days later, not
Yeah.
so great.
Well, it's not surprising. If something's kind of slipped a little bit, it could easily go back. I mean, I get the biomechanics of it, but when we had the Info Health program here, I actually made it my business to get to know one of the new chiropractors in town. So I was his guinea pig for the show, and it was taped. And I think the library still got it. It was kind of fun because he's actually still in practice, and it gave me a better understanding of what he thought he saw, and why he did this or that. And so in my mind, there is a case for it. And physicians can be definitely wrong about stuff that they don't know anything about. And there's a real prejudice, or was a real prejudice against that kind of thing. So we're almost done. Actually, we're gonna, where are we here? Oh, sorry, we're back. Oh, okay, here we are, epidural. This is one of the things that actually does work. And an epidural injection, for sure, of a glucocorticoid into the lumbosacral roots. Do you want to see this? This is a little tape. So let's see somebody. Yeah, it will come. It's not totally come. Let's see if it does. No. It should come. It did. I don't want to move it forward. Let's see. Oh, here we go. Now, the New England Journal of Medicine.
This is a video
Harvard,
of
this is
clinical
Harvard,
medicine from the New England Journal of Medicine.
one of the best journals in the world. It'll be slow because it's meant to be, but it's not long.
Lumbar epidural glucocorticoid injection is a procedure used for the treatment of lumbosacral-radicular pain. Glucocorticoids can be administered to the epidural space through the interlaminar, transforaminal, or caudal route.
Where's George?
This video will discuss indications, review relevant anatomy, and demonstrate techniques for epidural glucocorticoid injection.
This is nicely done. If you were trained this way,
The diagnosis
it'd
of
be great safe.
lumbosacral-radicular pain relies on the combination of symptoms, findings on physical examination, and results of diagnostic tests and imaging. Epidural glucocorticoid injection is primarily indicated for radicular pain radiating to the leg, as opposed to non-radiating axial pain isolated to the low back. The clinical presentation of lumbosacral
Actually comes
radicular
from
pain
Allen's paper.
varies according to the nerve root or roots involved. Pain and sensory symptoms are most common. Motor weakness and reflex abnormalities may also be seen.
By the way, this is all available on the library, so wanted to see it again.
Contraindications to epidural glucocorticoid injection include systemic infection, local infection at the procedure site, or allergy to the local anesthetic agent, glucocorticoid, or contrast medium that is being injected. Relative contraindications include ongoing anticoagulation with antithrombotic agents like warfarin, apixaban, or rivaroxaban,
Any
or
blood thinner.
antiplatelet agents such as clopidogrel. However, if the agents can be held for an appropriate time interval, the procedure can be performed.
This is the how.
To perform an interlaminar epidural glucocorticoid injection, you will need a 2-week epidural needle, a loss of resistance syringe, a local
So
anesthetic
that's
agent,
way in
a
back
contrast medium, a
between the spines.
glucocorticoid, and a fluoroscope.
That's what it's doing.
To perform a
And it's
transforaminal
on a
epidural
table that
glucocorticoid
spreads to
injection,
the heart.
you will need a spinal needle, extension tubing, a syringe, a local anesthetic agent, contrast medium, a glucocorticoid, and a fluoroscope.
This is a real gift to practicing physicians.
To perform a caudal epidural
really
glucocorticoid
is.
injection, you will need a TUI or Coude epidural needle or spinal needle, a local anesthetic agent, contrast medium, a glucocorticoid, a syringe, and a fluoroscope. Use of a catheter is optional. Explain the procedure to the patient, describing the benefits, risks, and possible complications. Obtain written informed consent from the patient or a proxy. The epidural space is an anatomical space located outside the dura mater and within the spinal canal. It contains fat, blood vessels, and connective tissue. It extends from the base of the skull to the sacral hiatus at approximately the S4 to S5 level. For epidural glucocorticoid injection, an interlaminar, transforaminal, or caudal approach can be used. The interlaminar approach involves obtaining access to the epidural space between the lamina of adjacent vertebrae and through the ligamentum flavum, usually with a loss of resistance technique. The
Meaning when you
transforaminal
punch through
approach
the hole,
involves
pressure
obtaining
comes out.
access to the epidural
Is it easy?
space through the neuroforamen. The caudal approach involves obtaining access to the epidural space at the sacral hiatus and through the sacrococcygeal ligament. For pre-procedural planning to identify the optimal approach, review magnetic resonance images of the lumbosacral spine obtained in the
That's what
axial
makes
and
it safe.
sagittal planes. Look for potentially
You know where
pathologic
you
structures
are.
that may cause technical impediments. Use fluoroscopic imaging in the antero-posterior view to identify the interlaminar space at the targeted spinal level. Administer the local anesthetic to the skin, and then insert the 2E epidural needle. Allow the needle to pass through the skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, and ligamentum flavum. Using fluoroscopic imaging in the lateral view or the contralateral oblique view to guide the depth of insertion. Once the needle has entered the ligamentum flavum, follow the loss of resistance technique to access the epidural space. As the needle passes through the ligamentum flavum and enters the epidural space, there is a sudden decrease in resistance to injection. Advancement should be stopped. This loss of resistance indicates that the needle tip is now in the epidural space. Administer the contrast medium and look for an adequate epidural
So
spread
it
pattern
knows where he
in at
is.
least 2 fluoroscopic views to confirm epidural access. Finally, inject the glucocorticoid with or without a local anesthetic.
And now the other options.
Use the antero-posterior fluoroscopic view to identify the vertebral pedicle at the targeted spinal level. Move the fluoroscope to the side of the body ipsilateral to the pathologic findings in order to identify a needle trajectory under the pedicle in the oblique view.
This is tricky.
The target epidural space is located above the corresponding dorsal root ganglia. Administer the local anesthetic to the skin and then insert the spinal needle. Use the coaxial view to guide the needle toward the target area. The final needle tip position is located at approximately the 6 o'clock position relative to the pedicle in the antero-posterior view. In the lateral view, the final needle tip position is located beneath the pedicle cephalad to the dorsal
You
root
see how
ganglia.
close it is to the root?
Administer the contrast medium through the extension tubing to confirm epidural access and to rule out vascular spread. Finally, inject the glucocorticoid with or without a local anesthetic.
And it's the last.
Use the lateral view to identify the sacral hiatus. Administer the local anesthetic to the skin, and then insert the TUI or Coude epidural needle or spinal needle. You can also insert a catheter to deliver the medication to the target area. After the needle traverses the sacrococcygeal ligament, administer the contrast medium to confirm epidural access in both the antero-posterior view and the lateral view. Finally, inject the glucocorticoid with or without a local anesthetic and saline. Possible complications associated with epidural glucocorticoid injection include dural puncture and post-dural puncture headache, infection, epidural hematoma, nerve or spinal cord injury,
The headache's far away.
and glucocorticoid-related effects such as hyperglycemia. This video has reviewed the indications for epidural glucocorticoid injection for treatment of lumbosacral radicular pain, as well as the pertinent anatomy, procedural techniques, and possible complications.
Yeah, so I think that's it. If very nicely done, and they're doing more of this, and thank goodness they are, because it's a good way of handling it, and you can do it in the clinic. Of course, it does depend on having a fluoroscope there to guide you, which not many clinics would have. So it's, I think we're done. Well, I already mentioned it, looking for a good fit if you're thinking about surgery. And I put in a plug here for London, because it's very hard to get paper in the New England Journal of Medicine. And they review a lot of back stuff. And this is London Health Sciences. And I know the lead author, Chris Bailey, is very, very good. His son's a co-author on this, a whole bunch of people. They have what I consider necessary for this, being a multidisciplinary clinic. They have neurologists, they have physiotherapists, or the rehab physicians, they have neurosurgeons, they have orthopedic surgeons, they have a whole support, and they all see it. And it's kind of a collective decision about what is best, non-surgical approach or surgical approach. That's what works. And I'll just finish on one note. Some years ago, Walmart was tired of paying big bills for their staff for surgery on their back, which didn't seem to work. And so they said, well, we'll pay the cost. And they made a deal with several of the leading medical centers, including the Mayo Clinic and the Cleveland Clinic, the two with the new group. And so the patients, airfare, hotel, all paid to get the best opinion they could about what should be done. And then if it was surgery, then it would be done there. It worked. It made it, the benefits were much better than the helter-skelter way of kind of dealing with it before. And the back is complex enough that it really does, it's like cancer kind of stuff, where they have a team approach, and everyone kind of adds their bit. So it's something to think about. Historically, neurosurgeons haven't been all that keen about it. They didn't want to do lower back surgery, and most of them still don't, because success rate isn't great, and they tend to be conservative. The ones who are keener about it are orthopedic surgeons, but who tend to want to sometimes put fusion in, which the neurosurgeons don't want to. And the only controlled studies that have been done, two of them went through the New England Journal of Medicine. The evidence was against fusion. So anyway, so there is evidence out there. It certainly isn't complete. It's really tricky because of all the factors that I've tried to touch on here. But it is complex. And I think if one's serious about if it's a serious problem clinically, then it deserves a serious answer. And that requires a multidisciplinary approach, I think. And more, that's what's happening in Canada and UK and Europe and certainly the States. So it makes sense in something that's so poorly understood and where everyone's kind of looking through their little hole with their biases. And so it makes a big difference to have different opinions on things, I think. So there is much more I could say, and I'm going to cut it off because we're over time. So next week, we raise the ante a bit. Trouble in the neck is not as common, but it's more dangerous. Why? Because the spinal cord is there. here, all of the trouble is south of the spinal cord. There, the spinal cord is right there, and you can't avoid it. So making decisions is more difficult. But the problems are fairly common, and so we'll talk about that next week. All right? That makes sense? Did you like the little video clip? Yeah, it's kind of nice to. Yeah, it's interesting, as I said before, that they are, the Harvard in particular, but the New England Medical Journal, which is really the Massachusetts Medical Society. That's who publishes all the stuff. So, so they're kind of working together, which is really good. And any questions before we break up? No? And how many in this group, small group, how many have had lower back trouble? God, there we are, 3, 4, 5.
So could you say that Beatrice have had what? I'm sorry, the hearing some. How many here have had what?
Lower back pain or sciatica.
No.
No, good for you.
No.
Yeah, you're the poster child. Okay, all right, well, that's very good. So we'll see you next week. It's nice to actually work with a smaller group like this, it really is, it's a plus. So thank you.
Thank you.
Thank you.